Can you get the...
La discusión, ellos suben aquí, yo me pongo ahí y tú te quedas aquí.
Sí, señor.
Y tú quedas muy bien.
Prendiamo gentilmente posto, grazie. Siete quasi perfettamente bravi, ma please sit down. One minute.
11:35, Andrea.
35, you said.
No, 5 minutes late.
No, okay. 5 minutes later is good. No, we start with 15 minutes. So.
No, I'm kidding. I'm just kidding. This is it.
Yes, but I think from Milan. Milan is not. Milan is northern Europe, so 5 minutes. But I'm sorry.
Ma ci doveva essere il musicista? Non c'era il musicista? C'era il musicista che doveva... E dove sei andato? Non me lo penso.
No, nothing. Only at the end.
Okay. All right. So we are going to start the last part of this session. And as you see in the program, the next speaker, the next session was Dr. Kathy Foley. Unfortunately, Kathy cannot be here with us for her family health reasons. And we will have the presentation from Kathy given by Professor Jim Cleary. And I'm happy to introduce Jim. He's an Australian-trained medical oncologist and palliative medicine physician who has been in the U.S. for 24 years. He has not lost his Australian accent, though. He's a professor of medicine at the University of Wisconsin Carbon Cancer Center, where he leads the Pain and Policy Studies Group, WHO Collaborating Center. And for the last 20 years has been a leader in improving the global access to morphine. And if you have ever seen data on the consumption of opioids and the graphs that most of us use, they all come from Jim and his group. Jim will start in a new position as Director of Supportive Oncology at Indiana University in July. So welcome, Jim.
Thank you, Liliana. Palliative care has always been part of my professional life. My mother was a hospice nurse when I was in high school. When I was a medical student, she gave the first dose of oral morphine in Adelaide, Australia. As a medical student, I worked in Calcutta with Mother Teresa for 3 years, and it is where I met my wife. I have much to thank Mother Teresa. It is she who told my wife to marry me when I proposed to her. So it really is a great honour to be giving this talk on behalf of Dr. Foley today. Whatever you like are my ideas, whatever you don't like are Dr. Foley's ideas. But Dr. Foley is a member of the Academy and has really been a great leader of palliative care both in the United States and around the world, and she is a member of the Academy. And I would like to compliment, praise, commend Monsignor Paglia for leading, directing the Academy to address this important issue. Thank you, Monsignor. So, I managed to squeak in the question mark here, David, and ask the question, does palliative care improve medicine? And it is what we will address today. In the United States, death talk is not popular. The Americans have a saying, give me liberty or give me death. For Americans, death is always a second choice. But I remind you that even in the United States, 100% of Americans die. See, it took a while in the Italian, eh? Even the Institute of Medicine has been addressing this over a number of years. And I commend these reports to you, that they're very significant reports addressing the issues that go on. Patients and families with life-limiting illness face enormous challenges. Poor care coordination, poor communication. Healthcare is the most common cause of bankruptcy in the United States. The most common cause of bankruptcy in the United States. And there is inadequate symptom control and psychological support. They have defined that there is an ageing population with chronic illnesses. There are expanding number of medical, surgical, pharmaceutical and device innovations that prolong life, sometimes only months. There is increasing prevalence not only in the United States but around the world, and particularly in Africa and Asia, of non-communicable diseases, especially cancer. And there are spiralling healthcare costs, which even in a country like the United States is resulting in great inequity and access to care. One of the challenges, and I think David raised this in terms of society and medicine, is that there has been a real medicalization of death. In the United States, it most commonly happens in intensive care units. There's questions about patients' rights and bioethics, and increasingly, and particularly in states in the United States, there is discussions on euthanasia and physician-assisted suicide. There is a real lack of guidelines to help us, and there is this term technological brinkmanship. I'm not sure how that's going to translate, but we'll see. This comes from Daniel Callahan, who is the founder of the Hastings Centre reports. This is the unbridled use of technology that has taken over much of healthcare. It neglects the care of the person. And who are the victims of this brinkmanship? Really whole person care, patient-centered care are the victims as we move forward. In our enthusiasm to cure, we forget to care. So Callahan recommends the need to support the care of the dying through healthcare professional education, policies, as Marie-Charlotte mentioned, model programs, and a broad public education, not just physicians. The community needs to know about and what palliative care is. So here is the definition from 2002, which has already been shared with you, and to look at some of the aspects: pain relief, affirming life and regards dying as a normal process. The 2002 definition brought in the word intends. The earlier ones didn't have it. But by intention, we neither propose to hasten or postpone death. It helps patients and families live as fully as possible and helps the family to cope. David talked about palliative care and how it can improve society in general, but he also has spoken that palliative care has encouraged medicine to be gentler in its acceptance of death. Dan Somasi has also looked at this. Palliative care emphasises a biopsychosocial spiritual approach to care. It helps patients and families set goals to care about difficult topics and enables better coordination of care to navigate care plans. Phil Larkin, who you will hear from later on today about Europe, has used some of the metaphors that palliative care adds to medicine. Being present, tending to or holding. And my wife is a hospice chaplain, and the children often speak about the fact that what she really does is hand-holding. But that sense of touch that is so important. Nurturing, looking at life through a patient's eyes, walking through their shoes, in their shoes, witnessing and compassion. So accompanying the dying has very many dimensions. The need to be present, providing unconditional support and solidarity, helping patients achieve a sense of completion in life, and finding opportunities for reconciliation, forgiveness, intimacy, and peacefulness. And this really becomes important as we look at people around the world. It's not just for people in the high-income countries, the global north, as David referred to it. This is for all people throughout the world. We need to develop the evidence base to bring about this practice. And there are a number of efforts around the world actually addressing this now. Collaborative research networks, Europe, United States, now growing in Africa and Asia. We're using standardized collection tools so we can make comparison, and we're establishing registries so that we actually know what is happening around the world. But I think, as David said it very importantly, patients don't necessarily care that much about, and Eduardo mentioned this as well, patients don't necessarily care that much about indicators and other things. They want care, compassion, and that is something we need to provide. So the evidence: palliative care increases patient time spent at home. Patient and carer satisfaction. Eduardo mentioned sitting down with your patients. Patients think you spend longer in the room if you sit down, even though you don't spend any more time. It's an amazing concept. So why we wouldn't sit down? Improved symptom control, reduced inpatient days, which particularly in the expensive healthcare of the United States is a huge cost saving, reduced overall costs, and patients are more likely to die where they want to die. There's improved communication and decision-making with the involvement of palliative care, improved mood and reduced symptom burden, and there's some evidence that there may be an improvement in survival. But I worry that if we focus too much on that, we're joining the industrial medical complex, which puts all focus on living as long as we possibly can, rather than quality of life. And we show that earlier to referral to hospice can actually be a soft cost saving in the United States. Palliative care allows patients to, and Kathy used the word to, I changed it to with. I think that is the language we have to change. It's not talking to patients, it's talking with patients. And that is something palliative care can bring to medicine. In our own hematology ward at the University of Wisconsin, I'm often accused of raising the question of death and dying with bone marrow transplant patients. I walk in and ask the question, what is your biggest fear? And what do most patients say? I am worried I am going to die. Would you like to talk more about this? And they say yes. And I am accused of raising the death and dying question. It is the elephant in the room that we are showing to other clinicians. Palliative care allows healthcare professionals to work in teams with unconditional positive regard for each other. We learn communication skills and model compassionate behaviour. I want to refer you to this particular IOM report in 2001, which talks about the skills required to practice palliative care. Most of us think that palliative care is just care of the imminently dying, the last one. But there are so many skills that we need to bring to the table, and this report highlights them. We're going to hear more about communication in the next speaker. But I think this is an important aspect if we look forward to the results of this study from Boston. And what it actually did was take people with metastatic lung cancer and colon cancer, and it asked them what were their expectations. And here is the summary, and as I'm getting old, I have to put on my glasses to read it. In this treatment, 90% of the patients thought cure was somewhat or very likely, whereas 74% of the oncologists said cure was unlikely or very unlikely. We are not communicating in medicine, in oncology, the goals of therapy. And this is really something important that I think palliative care can actually do. In the United States, there is this discussion, I think a discussion around the world. Scott Murray has led this initiative on primary palliative care. We need to teach all primary care providers a basic concept of palliative care. But we also need specialist palliative care for the difficult cases. But I, for one, don't want to see every patient who is approaching the end of life. I think it is a change in the culture of medicine that we need to bring about, that this is something that we do in terms of medicine. There are increasing certification programs around the world for multi-disciplines. It's not just physicians, nurses, social worker, chaplaincy, and I understand there are a large number of chaplains here, and I welcome you all to this meeting, such a crucial component. My wife said I had to say that. So, there is European certification programs, and these are all country-specific, but as we amalgamate more in regions, they are becoming region-specific as well. In the United States, the Joint Commission now has advanced certification for palliative care, which is based on consensus guidelines about what constitutes palliative care. We now have multiple textbooks on palliative care. And it's interesting, when I first moved to Wisconsin, studies showed that most medical textbooks and nursing textbooks did not even mention palliative care. That's the 90s. Now we have these wonderful textbooks that actually consider this. And we have an ever-growing number of journals across the board that address palliative care. Sometimes I worry that there are too many journals and I can't keep up with them all. We have guidelines across multiple disease. And even a number of us have just come from India, where in India the Palliative Care Association is working with neurology and intensive care specialists to bring about guidelines and changes in the way this is practiced in India. We need to address multiple populations and paediatrics, geriatrics, the developmentally delayed, lesbian, gay and transgender communities, sex workers. We sometimes use the word addicts, but the WHO would ask us to use the term dependency syndrome. There are real connotations, stigma associated with addiction, and also prisoners. But this is something that we talk about as being accessible in high-income countries, but we know across the world that many people don't have access to palliative care and pain relief. And this comes from a campaign in the Ukraine, which talks about that the 50 milligrams daily limit of morphine is not enough, and that this is the equivalent of torture. And the UN Human Rapporteur for Human Rights has talked about this in terms of the lack of access to opioids as being torture of our patients. The Lancet Commission was released in October of last year and will be formally released in April. And this is, I think, a huge document which really takes monstrous steps forward in addressing the abyss that we face in access to palliative care. It's often seen as second-class care, active therapies for the rich and morphine for the poor. And we even see that within countries. If you have enough money to actually go to a private hospital, you get the latest chemotherapy. Chemotherapy that now may cost $100,000 a month, even though it only provides some months of benefit. We have to be careful that we don't advertise our own cost savings to healthcare as a way of rationing care. For some, it is a vehicle for euthanasia and physician-assisted suicide. Well, people die when they're getting palliative care. Why don't we just facilitate this and rush it forward? And there's also the concern, has been mentioned, that we become just another specialty rather than really changing the culture of medicine. As Francis has said, it is the experience of the truly human attitude of taking care for one another, especially those who suffer. It is a testimony that the human person is always precious, even if marked by illness and old age. Indeed, the person under any circumstances is an asset to him or her and to others, and is loved by God. To finish with the words of Daniel Callahan, there is peculiar irony in the contention that in cases of severe suffering, our human dignity can only be achieved by having another person kill us or providing us with the means to kill ourselves. It is a way of saying that we cannot achieve dignity on our own in some circumstances, but must turn to the community to make it possible, at least to one other person to make it physically possible, and society more generally to make it legally possible. Yet it is a strange kind of community that would require consensual homicide to realise its members' individual dignity. Very powerful words. What I think we need to do is tell stories. We need to tell stories about the patients that we care for, and these are some examples of some stories. This is Life Before Death. Michael and Susan Hill have put together this series of videos which address this very importance. They also did this Little Stars for paediatric palliative care, telling the story of how important this is. It is demonstrating to the world, to our colleagues in medicine, to our administrators, our policymakers, that we can actually bring about this restoration of dignity to people wherever they are in the world. Thank you very much.